$629 for a bandage, $55 for one Tylenol tablet, $5,400 for a mucus recovery system, a box of tissues, even $25 for holding your own newborn. These are not billing mistakes. They are real line items from real hospital bills documented by ProPublica and filed with the Centers for Medicare and Medicaid Services. And when you actually look at the charges, every single one traces back to a hidden pricing system that has a name. Every hospital in America relies on a master spreadsheet known as the chargemaster. This is not a tool for patients or a guide for doctors. It is a price list maintained by finance committees and revenue managers who meet each year to adjust codes and set new sticker prices. Oversight is minimal. A bandage that costs the hospital a few cents might appear on the chargemaster at $7. The process is routine, yet the numbers are anything but ordinary. A study in the Journal of the American Medical Association in 2019 revealed that, on average, hospitals set their prices at 3.4 times the actual cost. This markup is not reserved for rare drugs or advanced procedures. It applies to the basics. A single Tylenol tablet, which costs less than 10 cents at any pharmacy, can show up on a hospital bill at $55. These are not mistakes. They are the result of a system built to maximize revenue, not reflect the real expense of care. But sticker prices are only the first layer. The real escalation comes from facility fees, charges added simply for using hospital space, staff, or equipment, regardless of how minor the service. Take the infamous $629 Band-Aid. Only $7 covered the bandage itself. The remaining $622 was an emergency room facility fee, a standard charge applied to every ER visit, whether for a broken bone or a scraped knee. Facility fees do not stop at the emergency room. When hospitals acquire outpatient clinics or physician offices, they often reclassify them as hospital outpatient departments. This administrative change allows them to tack on facility fees to every visit. In one case, a routine clinic appointment that once cost $95 soared to $845 after reclassification, with a $750 facility fee added overnight. National data from the Kaiser Family Foundation shows that, on average, facility fees add $1,372 to outpatient visits. These surcharges are embedded in the billing system, affecting anyone who seeks care. Most patients never see the chargemaster or realize when a facility fee is added. The impact is immediate. A parent brings in a child for a quick fix and leaves with a bill that could drain their savings. A routine follow-up suddenly costs several times more with no warning. The chargemaster and facility fee are the silent engines behind inflated bills, hidden, automatic, and designed to extract the highest possible payment. 1 in 5 emergency room visits once ended with a surprise bill, an out-of-network charge that blindsided patients who thought their insurance would protect them. The Congressional Budget Office put the scale into sharp relief. Before 2022, millions faced these unexpected debts every year, often running into thousands of dollars. The No Surprises Act aimed to close this trap, forcing hospitals and insurers into arbitration when they could not agree on payment and capping what patients could be billed. Yet the first-year data from CMS shows the law's limits. Surprise billing cases dropped by 31%, but providers won 78% of arbitration disputes. The system still tilts toward higher payouts, and enforcement gaps leave families tangled in paperwork and collections. The price gap runs even deeper. Hospitals set their own sticker prices through secretive charge masters, assigning eye-popping numbers to every supply and service. A mucus recovery system, essentially a box of tissues, appears on bills at $5,400 in several hospitals, while Medicare pays $1,400 for the same item. Negotiated rates for insurers are often less than half the sticker price, but uninsured patients face the full amount. ProPublica's price comparison table shows that even cash pay quotes offered as a supposed discount usually exceed what insurers negotiate. The gulf between what hospitals charge and what they accept is vast, and for the uninsured, it is a chasm. For patients, the fallout is relentless. Nonprofit hospitals, which receive tax breaks to provide community benefit, are required to offer charity care. Yet a recent study found that only 1% of patients whose bills went to collections actually received financial assistance. The rest faced aggressive debt collection, mounting stress, and the risk of bankruptcy. The promise of charity care is often out of reach, replaced by a system that pursues payment at all costs. Decades of policy choices and industry lobbying have built a system where sticker prices rarely reflect reality, and reforms only chip away at the edges. The numbers on a medical bill are rarely the final word, and the risk they carry is often hidden until it is too late. For many, the gap between what is charged and what is paid is not just a number, it is a trap that can change a life. Federal law now requires every hospital in the country to publish two things: a machine-readable file listing all standard charges, and an online estimator tool for at least 300 common services. The intent was clear: give patients the power to see, compare, and question prices before they get the bill. Hospitals that fail to comply face daily fines ranging from $300 for small facilities to $5,500 for the largest. The Centers for Medicare and Medicaid Services has sent out more than 500 warning letters since the rule took effect in January 2021, each warning hospitals to fix missing files, broken links, or incomplete data. But the reality on the ground looks very different. According to a 2023 audit by Patient Rights Advocate, only 21.4% of hospitals are fully compliant. Many post incomplete spreadsheets, leave out key items, or bury prices in hard-to-read PDF files. Some files group dozens of supplies under a single label like miscellaneous, making it impossible to find the price of a bandage or a Tylenol. Others provide a price estimator that only works for a handful of procedures, ignoring the hundreds of services that drive up real bills. Even when a file exists, it is often filled with placeholder codes, missing CPT numbers, or technical errors that block any real comparison. CMS has the authority to fine hospitals every day they fail to comply, but enforcement has been slow and the penalties are rarely collected. The result is a system where the promise of transparency exists mostly on paper. For patients, the numbers they need are still hidden behind layers of jargon, broken websites, and incomplete data. The law was supposed to make hospital billing clear. Instead, most people are left with the same confusion and the same risk of financial harm every time they seek care. Every inflated hospital bill is a starting point, not a final verdict. Patients have more power than they realize, and documented results show that pushing back works. The first step is always to request an itemized bill. Hospitals are required by law to provide a detailed statement listing every charge and code. A simple written request addressed to the Patient Financial Services Department can reveal hidden or duplicate charges. Patient advocates recommend using a template that cites your right to an itemized bill under HIPAA. Once you have the breakdown, ask for the cash or self-pay price. Hospitals often keep these rates unpublished, but a direct request can unlock discounts of 30 to 50% off the sticker price. Document every conversation, note the date, staff name, and quoted amount. If the discount is less than 30%, ask to speak with a supervisor or the financial assistance office. For comparison, platforms like Turquoise Health and Fair Health Consumer let you search Medicare rates and insurer negotiated prices by zip code. If the hospital's charge is far above these benchmarks, use the data as leverage in your negotiation. If you run into a surprise out-of-network charge or the hospital refuses to adjust the bill, file a complaint at cms.gov/no-surprises. Upload the bill, any insurance paperwork, and your correspondence. State insurance commissioner offices also accept complaints online. These steps can trigger investigations or settlements. ProPublica found that 68% of formal billing disputes result in a reduction, and 22% end in full forgiveness. Finally, check your eligibility for charity care before paying anything. Nonprofit hospitals must offer financial assistance, but the process usually requires submitting tax returns, pay stubs, and proof of residency with a formal application. If denied, appeal in writing within 30 days, citing the hospital's own policy and any state laws. Keep copies of everything. For many, these steps are the difference between financial ruin and relief. The odds are real. Most patients who challenge their bills see at least some reduction. The system is built to discourage questions, but persistence pays. This isn't rare. It's how the system is built. A chargemaster can turn a $1 bandage into a $629 bill. And facility fees or surprise charges routinely drive Americans into debt. Knowing your rights, questioning every line, and challenging unfair charges is no longer optional. It is survival. Demand transparency.